Thank you for the presentation. I would like to thank the scientific committee for the opportunity to present our work. Since its emergence in 2019, SARS-CoV-2 has globally become a major cause of respiratory illness. High-risk groups such as elderly and immunocompromised individuals remain vulnerable despite acquired immunity. Antiviral therapy plays a crucial role preventing severe disease. The most widely used antivirals are Remdesivir, that inhibits the RNA-dependent RNA polymerase, and Nirmatrelvir, that inhibits the 3CL protease. The increasing use of antivirals in the clinical practice has raised concern about the emergence of resistant strain. However, to date, both antiviral show a high barrier to resistance, with a few in vitro and in vivo resistant mutation reported. Here I have included some studies that highlight this. Our study aimed to assess the emergence of in vivo resistance after antiviral treatment and the in vitro genetic barrier of B1 and the Omicron KP3 to Remdesivir, Nirmatrelvir, and their combination. So, about the in vivo study, 101 pair swaps were collected at T0, so baseline, and after a median of 5 days of treatment from individuals mostly treated with Remdesivir, 6 with Nirmatrelvir, and 2 with both drugs, 1 in a combined manner and 1 in sequence. After that, the RNA was extracted and quantified by quantitative PCR, and swaps at both time points with CT values below 29 underwent full-length NGS by Illumina COVID-sec assay. Then the drug target genes, so the NSP5 for Nirmatrelvir and NSP12 for Remdesivir, were analyzed by Stanford CoV database to detect emerging mutation defined as those that increase in prevalence from 5 to 20%. Here we can see in the table the characteristics of our population. So mostly elderly people, most of them hospitalized, and half of them showed a nice score of comorbidities. The longitudinal analysis, including the 33 subjects whose swabs had a CT value below 29 at both time points, mostly harboring XBB1 and JN1 and their derivatives. Then, after the Nirmatrelvir treatment, no aminoacidic variation were observed in the protease, whereas 2 distinct mutations emerged in 3 subjects treated with Remdesivir, M794I and V792I. The last one is a well-known resistant mutation associated to a decrease in the susceptibility to Remdesivir. Maybe the isoleucine substitution slightly alter the conformation of the enzyme that lead to a decrease in the efficiency to incorporate the active form of Remdesivir. Whereas the M794I has not been defined yet. In parallel, we performed in vitro resistance selection experiments. So Vero E6 cells were infected with B1 and KP3 at increasing concentration of Remdesivir, Nirmatrelvir, and their combination. When we observed cytopathic effect, the viral supernatant was collected and used to reinfect fresh Vero cells at a doubled concentration of antivirals. the viral RNA was extracted and used to full-length NGS. Well, what did our in vitro experiment reveal? Well, B1 was able to replicate in presence of up to 256-fold the IC50 of each individual drug, developed well-known resistance mutation here highlighted in bold red. We see that as pharmacological pressure also increase the prevalence of mutation. We can see that the combination of Remdesivir and Nirmatrelvir inhibits the viral replication with a notably low concentration of antivirals than with respect to the single antiviral. In contrast, the KP3 appear less prone to viral breakthrough, so less prone to acquire resistant mutation. And also in this case, the combination with both drugs completely inhibit the viral replication. Here in this table, I've summarized what we know about the mutation that emerged from our experiment, all reported already in literature. I want to highlight the E166V for protease and the V792I for RNA-dependent RNA polymerase, because these are mutations mostly reported both in vitro and in vivo. So, in conclusion, in vivo, emergent genotypic resistance to antiviral is rare, with only one case detected among 30 Remdesivir-treated subjects. However, it's fundamental, the genomic surveillance, especially for immunocompromised categories, where the viral persistence may lead to an higher risk to select a viral mutant for antivirals treatment. And in vitro combination therapy with both drug strongly inhibits the viral replication of both strains, and that phenotypic assays on the mutant viral strain selected are ongoing. I want to thank my team from University of Siena and the other collaborators from University of Milan and Perugia, and you for the attention.